Hi, everyone. I'm Kamna Balhara. I'm one of the APDs at Hopkins. We just sort of developed a shared mental model of what trauma represents. And as we all know, there's been a really big push towards trauma-informed care for our patients. So as we know, more than half of the American population has experienced a traumatic event in their childhood. And so the AAMC raised this question: what if we treated every patient as though they had lived through a trauma? And we'd like to pose, you an additional question. Since we know that over half the U.S. population has suffered a trauma, this applies to our learners as well. So taking trauma-informed care, the next step is really taking these principles, not just from our clinical environment in patient interactions, but also thinking about how we can deal with the traumas that our residents or medical students or other learners have themselves experienced as well.
And unfortunately, the data shows that this is true, that about 50% of medical students before matriculating in a medical school have experienced a traumatic event in their childhood. And even more unfortunately is that our institutions of education further perpetuate trauma, which we all experience as learners. So about 64% of medical students over their time in medical school report feeling some sort of mistreatment by faculty, and 75% of medical students report feeling mistreatment by residents. This is particularly true during clinical rotations, where one study showed that 40% of students report feeling numb or emotionally detached during their clinical rotations. And this also continues on into graduate education, with over 45% of residents reporting some form of workplace mistreatment. This is often experienced as racial or gender discrimination and can be felt as either physical abuse or sexual harassment. And one of the most important frameworks that we'd like you all to walk away with today, either in providing patient care or as a learner or as an educator, is the window of tolerance. So the window of tolerance talks about how we, after experiencing a traumatic event, can be moved to a hyperaroused state, which is a sympathetic fight or flight response where we're agitated, we're sweating, our heart is racing, or a hyperaroused state where we disassociate from the environment around us. And I'm sure you can all think back to a shift, particularly challenging shift, where you may have entered into that shift initially with a positive attitude. You were excited to be there, you wanted to learn, you wanted to provide great patient care, and then you had an experience, maybe it was a patient yelling at you, that then flipped you into that hyperaroused state. After that patient was yelling, your heart started racing, you started sweating, and you definitely didn't want to be on shift anymore. And maybe someone intervened or someone comforted you afterwards, and you're brought back into your window of tolerance, and then another event happened. Maybe it was a nurse or an attending yelling at you saying, you ordered the wrong labs, you got the wrong CT scan, and then you shift into this hyperaroused state where you're disassociated, you're numb, you don't even care where you are anymore, you're just trying to get to the end of your shift.
So with that in mind, I'm sure we have all at some point experienced some variation of the supervisor/attending who is actually the inflictor of the trauma. And I'll give you a couple seconds to look at this comic by a graphic artist and physician who's fantastic. Her Instagram tag is down there as well, but I'll give you a second to look. So I think this just sort of demonstrates humorously, or perhaps not so humorously, because it's real life to some extent, but it does demonstrate how quickly these moments can be inflicted on learners. And it's also sort of important to think about what sort of traumas the attending or supervisor themselves has experienced that's led them to sort of this trickle-down effect of traumatizing people in turn. So people react differently when experiencing trauma. So certain things to look out for in learners or even in our colleagues would be things like reactivity and impulsivity, that sort of disengagement and numbness, a lack of curiosity or interest in learning, as well as the things that we might more stereotypically associate with this, including sort of anger or confrontational behavior. But people can also withdraw. And perfectionism itself can also be a downstream effect of having been in a traumatic environment.
So now, having discussed the prevalence of trauma, how we all experience trauma on shift, and what that can look like, we want to talk about the 6 principles of trauma-informed care, and then we'll go through the cases where we can actually apply these 6 principles in 3 different learning environments. And these 6 principles are safety, trust and transparency, peer support, collaboration, mutuality, empowerment, voice, and choice, and cultural, gender, and historical considerations. So up here is a QR code. We'd like you all to take out your personal mobile devices and scan this code. If you have a hard time, feel free to come up. This code has a link to a Padlet, which has each of the 3 cases and the interactive questions that we'll be using to discuss the 3 different learning environments and how trauma-informed care can be applied.
All right. So, sorry, I'm Dr. Jason Lewis. I'm from Beth Israel Deaconess Medical Center. So we're going to move on to the cases now. We'll have 10 minutes to discuss the cases, and I'll also be walking around with a microphone. But as Dr. Ashworth just mentioned, the Padlet will allow us to actually track your responses if you want to input them there. But anyone who wants to participate verbally, that will be an option as well. So the first case will be presented by Dr. Valdivia and Dr. Clery.
Hello, everyone. My name is Michael Valdivia. I am a recently graduated medical student. I'll be doing my residency at the University of California, Irvine, so very excited to start that in July. I'll be leading the first case. So once everyone pulls it up on the Padlet, we can already go ahead and get started. The kind of one-liner for the introduction for this first case is it's a resident who is showing signs of distressing, trauma reactivation. And then once you guys read the first case, you can already go ahead and start commenting on the first question, which is basically just asking, what are some of your concerns? What are you noticing in this resident during the first prompt? And I'll give you guys about 2 minutes, maybe even less, to kind of discuss that. We definitely encourage all of you to kind of do think, pair, share. If you want to definitely comment anonymously, you can do so on the Padlet. And then if anyone wants to say anything, we definitely have Dr. Lewis coming around with the microphone if anyone wants to say anything out loud. Does anyone so far have anything they want to say in terms of comments or concerns?
I'll just add briefly that in an effort to be trauma-informed with our workshop, we've got multiple levels of participation. So the Padlet, you can comment anonymously, but we will also walk around to, oh, you see some hands, let you participate verbally as well.
Hey, I'm Kelsey, I'm LSU NOLA. This has happened to me before, so it's kind of like a familiar experience. Personally, when I read this, sometimes I read a resident that's overworked, a little bit burnt out. And then I'm from New Orleans, so I've also experienced a lot of friends that may have died from gun violence. Every once in a while, those things do get to you, and this resident possibly may be identifying with that situation and needs to excuse themselves. So I think it's important for especially attendings in the room to kind of take that into account and take into account different people's experiences when they are going through these things, and just kind of check in and say, what's wrong? This may not be like you. Otherwise, some people may not know what's going on. They might need just a little bit more direction. So I think this was a good scenario. Thank y'all.
Thank you for sharing that. I think we have another comment right here.
Yeah.
Oh, never mind. Yeah, I definitely agree with you. I think in terms of attendings not understanding what may be going on with the resident, it could be, like we said, something related to a traumatic past experience. It could just be they just need, redirection for whatever reason, that they're just not paying attention. But I think definitely being a little bit more open and being more tolerant towards other people's backgrounds is definitely a great thing. Anyone else want to comment? I know people are discussing about doing debriefs and stuff like that.
Yes. Hey, everyone. I'm Blake. I am at WashU. I think for me, I've been in this situation as well where it doesn't even have to be a GSW, but just seeing a patient that looks like me that's affected by some type of acute illness or injury, and like seeing someone that looks like you, sometimes for me, I think that could have been me. And so I think as an attending, remembering if you've ever been in that situation as a resident, and also keeping that in mind that after like big, high stress events happen, which happens a lot in the ED, decompressing afterwards, kind of talking about it, is something that, you can do to like make that resident feel a little more comfortable and like kind of get them out of their head so that they can be more focused throughout the shift.
Hey, I'm Becca from UT Southwestern. What kind of support, like looking on into the future, if, eventually residents become attendings, like say you have a traumatic experience and you're trying to deal with this as an attending on shift, like who do you go to support? Like I know ER is like very collaborative and like maybe you can like pull one of your colleagues to help out in a trauma that you're being affected, or I don't know, what have y'all seen in your experience?
That's actually a great segue into like the second portion of the prompt, which is asking, how would you have like these conversations with that resident who's exhibiting signs of trauma activation? What tools can residencies have in terms of like workshops and stuff like that that they can use to, prevent the situation from happening in the first place, and then, promote resilience in our resident learners who have prior experience of trauma. So I believe we have someone who wants to comment.
I'm Erin Hammond. I'm at Wake Forest. So when I first read the prompt, I think there's a common assumption that it's related to the gunshot wound in that patient. But I've been an attending now several years, and I've walked in with that assumption, but then also been very quickly corrected or even identified that this may not even be related to the shift. Sometimes it's the workload. It's the fact that this gunshot wound that needs to be managed right now, and they're already 5 tasks behind on the other things. And so I think part of it is not walking into it making an assumption that why the patient or why your resident has changed or is acting different than you know them to be, and really starting with a question as opposed to an assumption as to what happened. To your point about kind of resources and what I've done, as an attending, when I see a resident or someone struggling, I ask them, I pull them aside. Often I'll excuse them from whatever else they have going on or see like what I can offload that would give them the space to process or do what they need. I think as an attending, it's hard to find that support for yourself. So sometimes for me, there may not always be someone else I can go to process depending on what's going on, but I do sometimes walk away and give myself a moment. Like sometimes I need to go to the bathroom and just process for a second, and depending on what the situation is, sometimes speaking with family helps. It all depends.
I think that part of it too is having an understanding of what trauma looks like, understanding of how that shows up, and you have awareness of that. Because until you have that idea, there's nothing you can really do to mitigate that. So kind of getting the things around you that are going to be scaffolding and support, whether that's a friend, whether it's therapy, whether it's a minute, but you have to be able to kind of feel the trauma and name it and notice how it shows up before you can do anything else. And one of our biggest barriers is a lot of attendings and a lot of faculty aren't aware of what that necessarily looks like and how that shows up. And it's not something that's commonly instituted. It's something that should be taught to attendants. So that's a big part of the barrier, is the lack of awareness of how trauma shows up.
Hi everyone, I'm Kyle Fisher. I'm attending at University of Maryland, and just to get to Becca's point a little bit more, I think it's really important that, especially in situations like this, you kind of know yourself and know, what the tiers of need might be. It might just be that you're in a place where you're like, just need to walk outside. Maybe I need to go get a cup of coffee. I might need a little bit, but then there can be situations where it can be a lot more. And I'll use my own story. A few years ago, I had a shift where there was a 2-month-old child that came in cardiac arrest, and I was a new father at that time. And that 2-month-old child had a birthday that was 1 day different than my kid's birthday. And after the arrest, I couldn't. I was like, I'm out, I don't have it. And my department chair was working that day, and they called in the on-call person, and I went home. I don't even remember driving home. And so I think we need to educate each other and give ourselves the permission that we're human beings and that there is a reason we have these systems and we have on-call and different people, and it is okay to say, I need help. So, and we need to support each other to make sure our culture is better.
I'll just add, since you mentioned that, I think that's super important, that vulnerability as an educator, because until, not only do we as educators need to be able to understand the signs of trauma, but for us to be open about what we're going through, I think creates an environment where learners can also feel empowered to kind of share what they're going through and ask for help. So I think we have to model that behavior. So thank you for sharing that.
Another thing to consider is being very proactive about the support systems that you put in place. We currently have a peer support system. We have a resident level peer support system. We have a sort of more global peer support system with, we don't schedule people specifically on a given time because they're on the peer support system, but if you are a peer supporter, then you sort of keep your eyes out in particular for people who may be struggling on a given day, or other people can point them in your direction so that you begin to develop both, specific identified people who have been trained in peer support techniques around reactivated trauma, but also you're sort of shifting the culture away from this being abnormal to this being just a normal, expected part of the experiences that we're going to have in our highly traumatic environment.
Yeah. Thank you, everyone. I'm loving this discussion and appreciate everybody, sharing their, own prior experiences and what they've learned from it. I think we're done with case 1 now. We're going to move on to case 2. Again, we're just going to keep open this dialogue and discussion, so let's just keep it going.
All right, thank you again, everyone. Now we have Dr. Brown and Dr. Ashworth for case 2.
All right. So you guys all have paper copies or the Padlet. So for case 2, the one-liner is you are going to imagine that you're faculty and you observe an interaction between another faculty member and a resident. All right, I want to thank everyone for participating anonymously. It's really helpful in a big group setting like this so we can get more voices. Hopefully this scenario sounds familiar to you all. And if anyone's open from the audience, it'd be great to hear some folks' thoughts. We have some great responses already on talking to your colleague, asking open-ended questions, vibe checks.
I particularly like the asking the attending an open-ended question. I think open-ended questions are a great way to have a pause and further explore what they're feeling instead of just jumping to a judgment as well. Because sometimes, I definitely agree with the vibe check from time to time, but I think open-ended questions are a great way to explore and come from a place of curiosity instead of judgment. Because sometimes you also just saw a glimpse of the room. You're not sure what had happened before, if there was something else that was also going on as well.
Hey, I'm Morgan. I'm with LSU NOLA. Something that we discussed back here is like initially the thought is like, oh, I'm also a colleague. I can say something to the faculty as a faculty person. But what we were discussing with our group is that a lot of our now younger faculty were also residents in our program. So we think although you guys are colleagues, there still is like that power differential of like, but this was my attending at one point. And so it may not be as easy to address a now colleague but former attending if an issue like this happens. And so my first response was like, oh, I'll reach out to the resident because we can relate on that. But I was a little hesitant to say something to the other colleague.
Hello, everyone. I'm wearing a Beckman shirt, but I'm actually an emergency room nurse. I see my people. And I just want to say that this happens all the time, right? And that's why you need a multidisciplinary approach to supporting residents. Because when I see a resident getting reamed out by an attending, I go into mama bear mode. And then what I'm going to do is I'm going to pull that resident to the side and I'm going to affirm that resident in the moment. I like to tell my, this isn't right for me to say it, but I tell my girl residents, it's seasonal allergies. When they ask you why your face looks flushed, it was just allergies. You weren't crying, you're gonna be all right. But I support them and I love on them in the moment because, you know, sometimes they do need to learn and listen and act in the moment because we want to save a patient. And sometimes it isn't always graceful, the message that's sent, but sometimes it has to be sent. I don't need to break down where we are in that whole continuum. I just need to support them in that moment so that they can finish their shift and then hopefully feel like they were supported from someone. And then, you know, if we're really honest with ourselves at the end of our shifts, we should be thinking, could we have done something better? But in that moment when you're feeling like, oh my God, I just got told off, there's an audience, people then, they feel empowered to now treat this resident like they don't know anything. You need someone almost immediately to just show you some love.
Thank you for your comment and thank you for your solidarity.
Hey, Mark, Baylor College of Medicine, Houston. So kind of to echo what everyone said, I'm not sure if I necessarily would confront my colleague just because if I'm a new attending, the power dynamic, things of that nature. But I would talk to the resident if they were involved. I kind of do this with my interns now. Remind them that, you know, even the best emergency doctor was once an intern who didn't know anything. So this is the perfect place to learn. This is the perfect place to make mistakes. If you're going to make mistakes, make them now. Because once you get out there in the field and it's just you, you need to know what to do if something goes wrong. So I think this is like a good learning opportunity. Also, sometimes, you know, people come into residency, like, you know, if you're coming up as a med student, you might feel like you know a lot more than what you do. And so I think these opportunities give you an opportunity to show where you can improve and where you can grow. So I always just frame everything as a learning opportunity. And I always, you know, let people know there's different personalities in medicine. You're going to encounter all of them. Just learn how to work with them and then learn what you need to do to succeed the next time you do it.
As a former program director and current vice chair of education, I really feel like it's the responsibility of program leadership to create a culture of support and to remember, as you just said, what it's like to be a new learner and how scary it can be to ask questions and build opportunities and safe spaces into your program in order for people to understand that everyone has felt like that. We implemented several years ago a program around that for our incoming interns that's sort of a 3-meeting longitudinal curriculum during their internship, and that really normalizes mistake making and allows them to create a safe space and to understand that, in particular, the residency leadership is a safe space for them to come to. And then on top of that, creating learning opportunities for the rest of our faculty that are based on trauma-informed care principles to make sure that everybody's on the same page about this.
Ernesto Romo, WashU, St. Louis. where I started from was before I approached my colleague, approaching the resident and asked them if they wanted me to say something. Because I feel like depending on the resident, they actually may not want me to to say anything. And so that's where I probably would start, is making sure they were okay and then checking with them on how they would like to proceed.
This discussion is incredible. This case does have an important part 2 that I don't want to miss. So in part 2 of the case, you do actually check in with your colleague, and then your colleague shares with you that in that interaction, they were really frustrated because they recently had a bad outcome with a resident, and that had a big impact on them. So wondering if anyone wants to share any anonymous thoughts or verbal thoughts about that.
So I wanted to share an experience around the approaching your colleague. And the reality is it's not easy. And I approached a colleague. They weren't necessarily directly attacking a resident, but what they were saying was very inappropriate in front of residents, in front of students. And I didn't ask anyone their permission because I can hear it, and so now I can engage and not have to, everyone knew I could hear it, so I could approach it almost as though like I was bothered by that too. It did not go well. I tried softly at first to kind of be like, hey, we probably shouldn't say that, don't you think, And they doubled down on it, and so we engaged in like an entire back and forth. And at the end of it, I don't think I changed their mind. I think if they left that conversation, they would consider saying something similar again. But the reason it was worth it is because everyone else heard that you don't get to just do that, and that someone is there, and then you see an advocate, even if I didn't have a specific resident that I had to go comfort or anything like that. But now that they know that there's an advocate who's going to speak up, someone around who's not going to just let people say whatever they want. And so I think it's just as important sometimes, because sometimes you all know that person who you look at and you're like, I could go tell them, but they're not changing, right? We maybe some places don't have that person, but but it's still important, I think, especially when others witness it, so that people can see.
And I'd love to talk about that more, but we're out of time for the second case, so I'd like to move on to the third one.
Yeah, thank you, everyone, for your comments. So our third case will be presented by Dr. Mabins and Dr. Winfield.
Hi, guys. We're going to move on to case 3. I'm sure you guys all have your papers in front of you or the Padlet. But for just a summary of the case, there is a shooting that happens outside of your emergency department. Multiple shots are fired, breaking the glass windows in front of the emergency department. And then there's a solo shot that is wedged in the metal door, the doors that you come in and out of every day, patients, residents, attendings. The next morning, you get an email, and they say, a single shot has been fired. But later on, when you talk to people that were there that night and you hear media reports that are released, there's a talk of 20 shots that were fired, a big discrepancy between what was released in public email from your institution and what people said happened in reality. Residents, attending staff all want to have discussion about this discrepancy, of how possibly the truth was not told, and a meeting is set up with the attendings only. So based off of this case scenario, what are ways in which the institution possibly did not have the back of the program or the residents, or provoked trauma in this scenario? I'll give some time for you guys to answer in Padlet, but also answer this question if you want or if you don't want. But raise your hand if you have experienced either personally gun violence for yourself, family members, friends. Have anyone in this room been affected by it? I have as well. I've been robbed at gunpoint multiple times. And so when there are stories locally, nationally, of there being shootings in emergency departments, and you call on the institution to respond, it's really important that trauma-informed care is taken into consideration with not just how we interact with our patients, but also how we interact, obviously, with learners and with the people who we work with. And so I think that is the goal of this whole presentation, is that we're very aware that trauma-informed care has a space outside of just with our patients.
Any comments?
Yeah, my name is Pradeep. I'm in Dayton Children's Hospital. I'm a PEM attending. And I worked in about 19 hospitals in the country in the last many years. So this is something, it's a very interesting topic, because if you look at ASAP and AAP, the strongest recommendation is for the safety of the children, patients, and the physicians and the staff. But then the institutions there's a big disconnect between the institutions and what we think that it should be done. So in my hospital, for example, we don't have a bulletproof, there's no, you can't walk through metal detectors because it's not, I think that when the local politics or the national politics and the state politics, they are strongly involved, much more than what I desire from my heart in these institutions, and those really have come to harm us. In fact, we have lessons in which we have talked when there's a shooter, what we should do, and I asked a question, you're supposed to run, but how do you know you're not running towards the shooter, not away? And there was no answer, and they are trying to have more ballistics recognition, and they'll do everything except they're probably installing metal detectors and not allowing guns or firearms into the building. And so even though there's a big push on AAP, ASAP has been strongly recommending for these things for a long, long time, the practice has been less than desired. It's not nuanced.
Go ahead.
I also want to touch on a couple of things that were played out in the scenario, kind of like a lack of transparency. And so if you recognize in the case that it was reported that there was only one shot fired, but in actuality there were 20. And so that within itself is called like missing assurances.
Minimizing.
Thank you.
That's all right.
Minimizing assurances. It's the intention of downplaying a scenario to benefit the institution, to make them look better in this scenario. And that within itself can increase the mistrust or with the institution and the people that work for it. So that also was done in this case.
Slacking.
Hi, everyone. My name's Mide. I'm from Baylor in Houston. I think this scenario is just kind of really close to comfort because I feel like violence in the ED is so normalized. Like, even if it's not a bullet, it could be a violent patient. I mean, we've had, instances in our ED where, patients have broken doors, broken glass, attacked nurses, attacked techs, and it's all just kind of like, no one really stops to think about how that affects you as a learner and those who actually work there. And then you have, in terms of just living in the United States, there's just that dark cloud of mass shootings that is just there all the time. And the fact that EDs that are so easily accessible don't have metal detectors is really crazy to me. I don't think we have a metal detector. I don't think we have bulletproof glass, and we've had maybe not shootings, but multiple instances of violence, as well as multiple times where we've had active shooter alarms that turned out to be false in the end, but definitely, creates, harm, and people, you don't get to leave work afterwards. You just kind of have to stay and keep going. And even when it's oh, that wasn't real, there wasn't a real shooter, it's in that moment, that creates so much fear. And we have had trainings, but I feel like it's mostly been like, I guess it's like run, fight, hide, but also like, I think we've had one where it actually talked about like, how would you protect the patient? And it's like, well, I don't know. Like, I'm probably gonna be thinking about protecting myself in that instance. So I think there's just a lot of just like, I don't think sometimes like we're looked at as people too, that also like have reaction to violence, especially when it's occurring on almost like a daily experience for us.
Yeah. And then there's a second part. We'll get to you in a second. Thank you so much. There's a second part to the case as well. So then later there comes a response that they're going to gamify the scenario by playing like a guess the price is right, essentially. How much does it cost to replace or to put bulletproof glass in the front of the hospital? And whoever can guess the closest cost wins a prize. There is people who disagree with this, saying that, it should not happen. We do not want to go along with this gamifying of a traumatic situation. But then several weeks later, a winner is announced. So how is this also causing trauma within this situation?
Okay, I guess my comment wasn't exactly about this, but I'm Megan. I'm from Detroit Receiving. I'm one of the residents. Actually, this past week, we had a nurse that was kidnapped 30 feet from our ER entrance door. It was, under gunpoint. There's an email that went out to the attendings, but nothing to the residents. I was on shift that day working. This was during like broad daylight. So all of a sudden, like slowly these rumors started happening, and it spread very quickly by rumor. And actually the first news report that came out was that there were multiple gunshots that were heard. There was no security presence. We had no idea what was happening until the like second news report came out that it wasn't actually like gunshots. It was just under gunpoint. And there was no debriefing. They brought like grief counselors in eventually because unfortunately she passed away. But it was actually a terrible scenario. And they bring in like grief counselors that were very specific for the nurses, but not for really anyone else. The timing that they brought these counselors in were not convenient to anyone in healthcare. So it was, very similar to this case, a little bit different, but, it has a lot of trauma that's associated with it that they don't address or bring up.
Yes, and then what you're also speaking on is like how this mistrust is, betrayal is formed between the people who work at the hospital, the staff, as well as the institution. And the betrayal of an institution is essentially, it's the failure to prevent or respond to any wrongdoing that's done when there's that very reasonable expectation of safety. And safety is one of the pillars of trauma-informed care. And so when your institution is not preventing or responding to the wrongdoing when there should be a safe space, this mistrust and this betrayal continues. And it seems like it also, not just in this case, but unfortunately happened with you two. I'm sorry to hear.
And to Megan's point as well, the goal is to engage all shareholders. So you'll frequently see, and that was part of the trauma in the initial part of this case, is it's an attending-only meeting. And it was only done as a response to people complaining about the lack of protocol. And so everything's very reactive. It doesn't include all shareholders. We forgot our nurses. We forgot our ED techs that run outside to retrieve the, it's just institutions in a lot of different ways, and their lack of transparency, their lack of policy, the lack of response and providing the necessary scaffolding and support to staff can perpetuate trauma and make it worse. And you didn't even have to make a game, could have just, we'd done enough. So. Anything else? Anybody?
And then just things like takeaways, some positives to try to do in these situations. You can always do like an internal survey, getting understanding of like where your faculty, your residence heads, your attendings are, and trying to make changes based off of their feelings to the situation. I think that can help with like the relationship between the institution and the people that work there. Thank you, guys. Oh, I didn't introduce myself. I'm Sanche. I'm a PGY3 from Cook County. Thank you, guys. Thank you.
I'm going to try and switch this back over to our other slides, but this may be beyond my IT capabilities. All right, so from now on, we want to protect some time for open audience discussion and Q&A. At some point, I hope to pull back up our slides. So just to summarize some of the things we talked about today, we started with a case where we had a resident exhibiting signs of trauma activation on shift. We then talked about how to engage our colleagues in creating a trauma-informed learning environment. And then we zoomed out all the way to an institutional level to think about how trauma can be both perpetuated and mitigated at an institutional level. I want to share just a couple learning points. Today's talk, I hope that you've taken away that trauma is a pretty universal experience for both our patients and our learners. We can use TIC as a framework to help support our learners and increase their engagement in learning, and then thinking about it at both an individual, interpersonal, and institutional level. We have our second QR code of the day, where if you scan this one, it links to a Google Doc with some collated resources on TIC if you're interested in learning more. And then we have about 5 to 6 minutes left that I want to leave open to any of y'all's ongoing comments, discussion, or questions for our 8 amazing panelists.
I just had a quick question, especially for the attendings. Something that we talked about is that especially in institutions that are very trauma heavy, it almost becomes like a badge of honor of who can see the worst and stay, or who saw the worst case and can still talk about it. So how do you guys, or what do you suggest to implement to kind of change that culture of not wearing things like that as a badge of honor and creating that safe space for people to not be okay, like making it okay to not be okay with what we see every day?
I'm not an attending, but can I comment on something that I think really helps? Debriefings, I am a huge proponent of that. I think when there's that space afterwards to discuss not only the case from a medical side, but to just like put your pulse on everybody and see like, how are you actually doing with this? Like we mentioned pediatric codes before, some traumatic arrests. I mean, it's very difficult, especially depending on where you work and being a person of color, to see people that look like you and all the traumas coming in, it looks exactly like you, to getting a sense of like, how are you feeling on this moment? It's okay not to feel okay, and then move from that to then talking about the medical aspect or how you guys could have done better as a team to help with the patient. But I think allowing that space, I think is helpful as a resident. Psychology on a lot of this is very well studied. I think we're very behind in we're very behind in GME. But I think, you know, it's the masculinity contest culture that we have in medicine, and in a lot of spaces where you're not supposed to admit that you failed at something, or that you're weak, or that you're unsure. And so we perpetuate a lot of that. So unfortunately, this is like a very ingrained, deep cultural, psychological thing that takes time. So for me, I'm constantly running my mouth, and I'm constantly telling people and calling things out. You know, and so that's just my little way of doing that and speaking at places and trying to get people to understand that, you know, and I just try to be that change every day on shift and trying to take my trauma-informed approach and reminding people of that all the time. And if I'm getting on their nerves, I don't care. So. I'm a
Hi, my name's Day. I'm a research fellow at UCSF. I'm really curious about what metrics or just like effective strategies you've seen to address this on the institutional level. I feel like maybe if like one like policy was in place that like after every traumatic encounter there was a debrief and like people measured that would really go a long way towards making change. So is that something that you've been able to like advocate for? Are there any places that are doing that effectively that maybe can be replicated?
I think in medicine, trauma-informed care is still in its very early stages. So Henry and I just did a systematic review, which is linked in this resource guide. In emergency medicine, there's very limited outcomes data. AHRQ is just now doing an analysis of outcomes in trauma-informed care. That's still open for comment. So I think in medicine, we don't have that data to say what interventions are truly effective. So you have to look out to other industries, the juvenile justice system, education, social work, they've been at this a lot longer. In terms of how any of those interventions like directly translate over to medicine, I think we're still working on it.
Dave Doom from Highland Hospital. I think there were a lot of comments that touched upon what I think can change culture, because there is this culture of masculinity, culture of wearing trauma as a badge of honor, and I think you guys kind of mentioned it, to change cultures, changing the norms and changing expectations. So if the norm is to debrief, if there's an expectation to do so, and yeah, that's kind of hard work. I think the question was from a program director standpoint, that starts with faculty development, and then move on from there, but also talking to the residents and making sure that this is something expected, that the residents should expect as well too.
I realized that I didn't introduce myself before. I'm Carrie McCabe from Boston Medical Center, and thank you very much for bringing this platform, or bringing this subject to this platform. It's something that I think about a lot, and I'm really glad to see that other people think about it a lot too. And I would just add food for thought that in our role as attendings and residents, in particular as attendings, as the people who are sort of supposed to be providing the culture, but also training the future generations, that oftentimes our populations in the emergency department have much higher histories of trauma in their past, much higher ACEs, and also our nurses may not either be familiar with trauma-informed care, or they are continually experiencing traumas of their own that are different than the traumas that we are experiencing as physicians in the emergency department. And so I don't have a solution to this. I have a lot of ideas about it, but I feel like balancing our learning, our training, our cultures, and how we all, how we advocate for respect for everyone's trauma coming into the situation can be super challenging. And I think it's worth it to keep trying, but obviously, but it can be really difficult to balance all of those particular traumas in a moment. And that just, the reason I support this so much is that what you're doing with this presentation so much is I think that the best thing we can do is be as widely educating as possible about what this means. So I really appreciate it. Thank you.
One last question? You want to talk real fast?
Yeah. One quick, very tangible thing along that line that I think about a lot is how we all have predicted a didactic time. And I think sometimes trauma-informed care gets put as like a subset of a didactic that's like once a year in a rotation. And thinking about incorporating trauma-informed care throughout all didactics, whether it's a procedure, how to, like any procedure, chest tube, peripheral IV, doesn't matter, you could take a trauma-informed care approach to that, and how to incorporate that framework throughout all your didactic across the year, and not just like a little something we pay tribute to kind of like once a year at a specific time.
Hi, I'm Sanche. I'm one of the PGY2s at LSU New Orleans. My question, coming from such a trauma-heavy program, is mainly for the attendings and program directors in this room. How do you find resources for your residents and your medical students who are training at such a program that's seeing gunshot wound, stab wound victims on a daily basis? How do you not react to something that was a very traumatic experience and instead support them proactively and give them resources or something to help their mental state?
One of the things that we've tried over at Clery is specifically asking residents and nurses what the things are that are barriers to them to like feeling trauma from leading a case or a shift, knowing that they like were able to do the best care that they could or be affected by it. And so, thank you. So that informed some of our quality improvement metrics, or quality improvement projects, and specifically the biggest one was communication. And I think it goes a lot to what our learning environments are. And so communication not only between the patient and the provider, but also between team members. And so we actually created a checklist around our ATLS, around how you talk to the patient, how you let them know what's going on, so you know you're not re-traumatizing them, but also how things were
are tied up at the end by a team leader. A nurse can call for a debrief. Anyone part of the team could call for a debrief. And sort of standardizing some of that gave us initially the language to talk about it, and then some tools to implement in real time.
It's a really good question, and I'm going to tangentially answer it because I think if we're all being honest, there just aren't the resources that we need, if we're just going to be honest. So I think one thing that's really important is that we find ways to make sure that we keep things in check so that we all are attending to our emotions and our patients at the same time. And we have this really weird area in emergency medicine where we have to be humanistic with our patients, and because we all came to it for the right reasons, and we love our patients, and we love taking care of them. But we're in a job too where you also have to, for example, if you're doing CPR, you have to dehumanize that person because it is torture if you don't. And so we have to have these little tiny interventions, if we call it them, where we can bridge the gap. So we can go between those moments of dehumanization back into humanization. So, you know, one tiny little example is one thing that I try to do for every cardiac arrest when someone passes away is different from a debrief, but just a brief moment of, I want to take a moment to honor this patient. We all just met them and we don't even know this person's name yet, but we know that there are people that are going to be crying tonight because they have friends and family that loves them. And it recenters ourselves so we don't just walk away as like, we just did CPR and did chest compressions and we did all these things where they were basically not a human being, but we're coming back afterwards. So I think finding ways to embed that into like everything we do is really important, but that's just my philosophy.
Thank you so much for sharing that. Thank you so much for everybody for coming to participate in this talk today. As a respect for everybody's time and the next meeting that's coming, we are 5 minutes over. So thank you guys for this engaging conversation. Have a good rest of your conference. Bye.